Good morning.
Good morning.
I'm Kevin Rathke. I'm a pediatric neurologist and epileptologist at Duke University, and I'm director of the Ketogenic Therapy clinic there. And we have with us today our ketogenic dietitian, Candy Richardson. So at the end, if you have more diet questions, she could answer some questions as well. So the ketogenic diet, what is it? I prefer, in Europe they call it ketogenic dietary therapy, which I like better than ketogenic diet, because you bring up ketogenic diet to people, they either know somebody that was on keto for weight loss, or you talk to other providers who don't think it's a real therapy. And it is, it's a therapy that can help epilepsy. And what we're doing with the diet is helping your brain choose ketones over glucose as fuel, and the ketones help reduce seizures. And that's a very simple way of looking at it. A lot of parents come in wanting something natural, and the ketogenic diet really isn't natural. It's very unnatural. So you need to monitor. These patients need to be monitored regularly. And the most important thing is you need a very good dietitian who's invested in it and well-trained, because all the questions are really answered by the dietitian. The ketogenic diet, or the idea of fasting for seizure control, has been around, or first noted in the 5th century BC, where Hippocrates described a man who, with epilepsy, became seizure-free from complete abstinence from food. And then in 1911, there was a report of 20 patients that did better in terms of seizure control with starvation. More studies came out after that, again looking at fasting and starvation for seizure control. But in 1921, Russell Wilder from Mayo Clinic, he coined the term ketogenic diet, and he did it not starvation, but reducing carbohydrate, but providing enough protein and nutrition for patients. And Johns Hopkins is really where the ketogenic diet took off. It's really where they perfected it, and they started doing it back in 1936. It didn't really catch on everywhere else for decades after that. So when patients come in, before we even start the diet, we have to decide, who should get it. And I think if it's appropriate and it's safe for the patient, there's no contraindications, it's something that should be brought up. I usually bring it up when I see a patient back after we've diagnosed epilepsy. We talk about, implanted devices like VNS, we talk about medications, we talk about ketogenic diet, we talk about all the possibilities, and then make a plan. The International League Against Epilepsy recommends that after failing 2 medicines, so when you become refractory, we often bring it up before that. And sometimes you have a very knowledgeable and eager patient or family that wants to start it as a first-line treatment, which we've done as well, and it can be very successful. There are some contraindications: mitochondrial disorders, carnitine deficiency, defects in fatty acid oxidation, pyruvate dehydrogenase deficiency, and porphyria. So you want to rule these things out before you would start the diet. And we usually have a good family discussion. You want to avoid...
And sometimes the dietitian and doctor need a conference on the patient care.
and make it work. There it goes. Same problem I had yesterday. And one question I think is kind of interesting to ask, and a child who can answer, is what's your favorite food? Because 2 patients we've had, one was one that his first answer was Captain Crunch, and he tried it and he could not do it because he missed that. So it kind of told us that he's going to be a hard one to stay on the diet. And another one, it was his mother's tamales, and he cried and cried and ended up not going on the diet because that was the one thing he'd missed. And you want to know what the family really wants from the diet and what they expect from the diet. And they have to understand that there's going to be follow-up, there's going to be monitoring, there's going to be blood tests. And we usually do blood tests every 3 to 4 months, making sure that we're not causing harm from the diet. And before testing, we like to do more testing to rule out other things. We do electrocardiogram, acylcarnitine profile, amino acids, organic acids, ammonia lactate, L-carnitine, and their vitamin D level. And when we talk to the families, we've got to look at what medicines they're on, because medications contain a lot of carbohydrate, especially liquid medications. So some of the newer ones don't. We know that Epidiolex, or CBD, by its nature being in an oil, doesn't contain carbohydrate. And fenfluramine or Fintepla doesn't, but just about every other one does. So usually we end up switching them to tablets if they have to take a liquid or they're tube fed, and we have them crush up the tablet, mix it with water, so they can administer it that way. And the tablets do contain carbohydrate, but much less than you would get in the liquid formulation of the medication. And that brings up, when you're going to start somebody on the diet, do you have things set up correctly in the hospital? And this has been a problem on and off for us for many years. Do they have the right form of the medicine available in the hospital? And who will prepare it? Is it the pharmacist will crush up the pills and put it in? Will it be the nurse, or will it be the family? And for some reason, hospitals don't like the family to do it, even though they'll let them prepare food. So it can get complicated. And then meals is another one. You want to know, is there a dietitian available in the hospital itself? And can we get the formula we want? Can we get the food we want? And who's going to prepare it? And a lot of times it's easier just to have the family prepare the food. And then also, because of stress response and things like that, you want to be able to monitor the patients while they're in the hospital. And you need a team and the appropriate people knowing what they're doing so we can safely monitor these patients. So what is the diet, for those who don't know? So it's a high-fat diet with moderate protein and low carbohydrate. And we look at it in a ratio. So in children, it's typically 4-to-1. So 4 grams of fat to every gram of protein plus carbohydrate. So typically it's 70 to 80% fat, and we want good fats, 20% proteins, and 5 to 10% carbohydrate. And adults tend to tolerate and have to go in lower ratios, such as 1-to-1 to 3-to-1. Originally, when we did the diet, we'd put you in the hospital and starve you to get it going and just give you IV fluids. And that made you ketotic a lot quicker, but it was kind of miserable torture. So now we just start the diet. It's a little slower to work, but it's tolerated better, and you're less likely to have people fail and want to come off the diet. The modified Atkins is kind of like keto light, and it came out in 23. It was funded by the Atkins family from the Atkins diet. And it's really more of a looking at labels or looking at a table like that and figuring out how to avoid high carbohydrate. So children tend to have a 10 gram of carbohydrate per day limit, adults 20. And it's essentially, like I said, a keto light, like a 1-to-1 or a 2-to-1 ketogenic diet. It has more fat than Atkins, and usually they go on MCT oil, which is more easily broken down into ketones by the liver. Which brings us to this. So you eat all these fatty acids, it goes to your liver, it's turned to ketones. Beta-hydroxybutyrate and acetoacetate. The acetoacetate is turned to acetone very quickly, where if you go to somebody who's on the ketogenic diet or somebody that's in a starvation state, you can kind of smell the acetone on them, and those are their ketones. We can measure them in the blood or the urine, so parents have little urine strips, or more accurately, they do the blood. The level of ketosis does not necessarily mean they have better seizure control. It may, and we try to keep them kind of on the upper level of having their ketones, but it's more of the measure of how are they doing on the diet and their compliance on the diet. How they help seizures is not fully understood. There's all these theories how it may modulate mitochondrial activity. It may affect channels in the nerves themselves, or it may indirectly affect nerve receptors. And then recently at the global ketogenic meeting we were at, there's some theory that it affects the pH within the nerve itself, which may help seizures. It can be pretty efficacious. Again, to have efficacy, you have to be pretty strict on the diet. About 75% of responders respond in the first 2 weeks. Over 50% of children who start it will have a 50% or greater reduction in seizure frequency. And that's similar to a lot of the medication studies that you see, but it has a different group of side effects. And it can work where children have failed multiple medicines, you can still get a response from ketogenic diet. 10 to 20% of children may get 90% or greater reduction in seizures. And again, as I just said, it's independent of the number of failed medications. So, when we get to our fifth medicine, we always say, the chance of another medicine working is pretty slim. But you can't think that way when you think in terms of the ketogenic diet. And again, it's still not for everyone. You have to have somebody that's committed to stick with the diet, because if you don't stick with it regularly, it doesn't work. We had a patient recently who every Sunday they had a cheat day. And we try to explain that when you have a cheat day, you're just setting yourself back, and then you're trying to get ketotic again. And we had another one that was eating a cake pop during his appointment. And yeah, there's a lot of education involved in what to do. Again, a good dietitian is very important because there's a lot of meal planning, what supplements to go on. It's easier for families if the child has a feeding tube because there's available formulas, and there's both milk and plant-based formulas. If that goes off again, let me know. I'm so sorry. It's not without side effects. Poor growth, kidney stones. Sometimes we supplement with citrate to avoid that. Renal ultrasounds, especially when we do urinalysis, if we see any blood in the urine. And then hyperlipidemia. Typically, that seems to be in people who have a genetic predisposition, so something you'd want to get in the history when you first see the patient, the family history. And if it's severe, it can lead to pancreatitis. So that's one of the things we check regularly when we see the patient back every 3 to 4 months. They can get nutritional deficiencies, the vitamin D, vitamin B. They can also have less common selenium and zinc, and it can lead to osteoporosis. There's question of whether or not bone density scans should be done. We've started to do them, but there's no kind of approved protocol for when to do it or if to do it. And one of the problems with that is in children, there's not norms for what their bone density should be, so it makes it hard. But we have an endocrinologist that has offered to look at them and tell us if he thinks that it's leading to osteoporosis. Constipation is a very common side effect. And that's usually we put them on mineral oil or polyethylene glycol, increased fluid. Reflux, and we usually have to treat that with H2 blockers or proton pump inhibitors like Prilosec, those kind of things. And rarely it could exacerbate cardiac arrhythmias, and that's one of the reasons you get an electrocardiogram before you start it. Usually we look for long QT syndrome. Well, then they're on it for a while. When do you stop it? Well, if you get to a point where you're happy with the results, kind of like we do with medicines, things are doing better, could we try coming off of it? And some families bring it up because it's a lot of work and they want to see if they can, not do it anymore. Or if they're unhappy with the results. They're on it, we're not seeing that much improvement, or we've seen side effects, or seizures got worse, something like that. How long can you be on it? You could be on it forever, as long as you're monitoring things. We know that if you're on it 6 years or more, your risk for kidney stones goes up to about 25%. Bone fractures with osteoporosis can go up. We know that slowed growth can occur throughout it, but it seems to decelerate further after about 6 years. And then hyperlipidemia can be a bigger issue after 6 years. Some centers stop at 5 to 6 years. They just say you have to come off. We have a lot of kids that are on it longer, but as long as you're monitoring things. There was a consensus guideline in 2018. So to see if it's going to work before you stop it, you want to give it very precise 3.2 months before you consider it a failure. So you got to stick with it for a few months before you say this isn't working, unless the seizures get worse when you start it. And at each visit, you discuss, are there concerns? Do you want to come off it? Do you want to stay on it? Because you need the family involved if you want to be successful. How fast can you come off it? You just don't want to stop it. Now, if you're having increased seizures, you might do it very rapidly. But typically, it's you lower the ratio over 1 to 3 months. Higher ratios, you go slower. Lower ratios, you can go faster. And then you want to monitor tolerability as they come off. If they've been on the diet a long time, you might have to go slower. And if they're not seizure-free, you might want to go slower. Again, we don't know for sure. Do the seizures recur? 14 to 20% of those recur. Of those who were seizure-free on the diet recur. It's probably higher for those that weren't seizure-free. Again, another reason to go off more slowly if they're not seizure-free when you decide to discontinue. Are there other uses for the diet? A classic one is GLUT1 deficiency, where they have the glucose transporter, which helps push glucose from the blood into the brain to the blood-brain barrier. And that's what it looks like. A little complicated. Patients can have variable clinical courses based on what the mutation is. So they can be very mild and show up with seizures, movement disorders, or behavioral issues at 2 to 3 years of age, or they can have intractable epilepsy from birth. Ketones freely move in and out of the blood-brain barrier, so we just bypass that system. Treatment is typically lifelong. You want to do it especially during formative years because your brain is starving. It's not getting the nutrients it needs, the glucose it needs. So you want to give it some sort of energy. Beyond that, a lot of adults stop the diet, and there's really not a lot of data to say, is that a bad thing? Is that a good thing? But we know that at least in childhood, they probably need to be on the ketogenic diet pretty strictly. Infantile spasms, we're using it sooner than we used to with infantile spasms. And it's thought that maybe it should be the second line. Usually for infantile spasms, we start with something like ACTH or steroids. We go to another medicine, vigabatrin. But usually if they're failing the steroids and ACTH, you're probably not going to see a response to another medication. And that's probably the time to think about ketogenic diet. And up to 50% of kids can have seizure freedom on the diet. And greater than 90% in about 70% of patients. The other one is status epilepticus, and we don't use it as much. A lot of the ICU doctors don't like to use it for status epilepticus. They want to use something else. And I think this goes back to the ketogenic diet versus ketogenic dietary therapy, is they don't think it's a real treatment. Status epilepticus is a seizure lasting 5 minutes or greater, or multiple seizures without return to normal functioning in between. Then there's refractory status epilepticus, which is if they fail 2 or more medicines, and then super refractory, which is refractory that goes over 24 hours. And the outcome of those prolonged episodes of status epilepticus are pretty bad, 30 to 61% morbidity, where they have permanent issues, neurologic issues, physical issues after status epilepticus. And then mortality is up to 44%. And there are studies that show in the super refractory status epilepticus, 70% of patients can have resolution of their seizures within 1 to 10 days. So we know it works. It's just getting people on board to want to try it. There are other uses. There's less data on these, but it's being tried in brain tumors and other malignancies. And one that there's more and more research on is mental illness and bipolar disorder and schizophrenia. So in the next 10 years, we may have more information on that. And that's it. Any questions for me or our dietitian? Yes?
Is it talking good about how fatty liver?
Really, if you monitor things, it probably wouldn't. In fact, if Candy, did you have some? She'll have something.
There is evidence that ketogenic
That was my next. Yes.
So I want to, just the previous slides you mentioned that it's not recommended for status epilepticus, but then you kind of.
No, it is recommended. No, I'm sorry. We use it for status epilepticus. It's getting people to use it for status that's difficult.
Oh, okay. But it is effective for status.
It is effective, but we can't, even in our institution, when we bring it up, we hit a wall because the intensivists, again, they don't think it's a real treatment.
Okay.
I know, it doesn't make sense.
But
But,
you okay for absence, status epilepticus, absence
yeah.
as well?
mhm. Yes.
Can you explain a little bit about, so my son's been on keto diet for about 6 years, or modified, he's now on
Mhm.
modified. But when you meet somebody off the keto diet, how does it still work? You know what I mean, like, if they stay seizure free?
So it's the same with, well, there's two theories. There are some theories that the ketogenic diet actually causes permanent changes in the brain that may help seizures. And that's similar to some of the theories with VNS may make permanent changes. The other is, we know, I always say kids are a work in progress. Kids change, grow, develop, and so sometimes they can overcome seizures. That's one of the reasons kids can come off medicine too. So in adults, it's probably less likely that you're going to be successful coming off, but in kids, after a few years, they're almost a different person. And I think it's more them getting better than our treatment's making them better. Yes?
Did you ever see where it does help with the seizure control, but then it loses efficacy after a period of time, or?
We have, and when we've adjusted it and increased the ratio and things, and it just doesn't seem to hold them. Again, I think of it a lot like a medicine, because it has some of the same responses like medicine. Most of the time they don't lose it, though. They usually can maintain it, as long as they're maintaining the diet. Any others? Yes?
What does it mean to be a level 4 epilepsy center?
That means you have everything. Surgery. It does not include ketogenic diet. So it's everything else but ketogenic diet. That's not included in your levels. But it's really that you have...
Level 5.
What?
We're level 5.
Well, as you go up, but it's that you do the monitoring and you do the surgery. So it has more to do with those types of therapies than... Any others? Well, sometimes if you stop suddenly, it can. And it could, just like when you stop a medicine too quickly, sometimes you'll promote a seizure that might not have occurred if you slowly came off the diet. So that's why it's better to slowly come off of it. But we do have patients that, especially teenagers, that will stop it. They want to eat what everybody else eats, and they'll stop it suddenly, and their seizures will get worse. Sometimes their parents don't know that they're eating. What was the one kid eating at night? I forget. We had one kid that was sneaking with his brother and eating, what was that kid? Chips and all this other stuff at night. His parents had no idea, and his seizures were not controlled. And then when he was in an appointment, he fessed up and said he and his brother do that frequently. Yes?
Can you compare a gluten-free diet like celiac disease to keto?
It's, I mean, a lot of the kids who are on on keto essentially are gluten-free diet, because you're cutting out all the things that have gluten in it. They're kind of probably doing different things. Those that have the gluten sensitivity, it's probably more of an inflammatory response, where it's our anti-inflammatory response being on the gluten-free diet. But with keto, it's probably not that. But again, you're kind of doing both when you're on ketogenic diet.
So was your question in terms of
Seizure control?
epilepsy treatment?
Yeah, it's me. I have celiac disease, and my seizures are very controlled now. Now that I'm cutting everything I like out.
Well, and if you're cutting all the things with
Doing what's carbohydrates.
right,
Yeah,
so
that's
you
disgusting.
you may be on kind of a modified Atkins diet if you're cutting out all those things. So you're kind of doing two things at once.
Yeah.
So yeah.
Okay. Just that. I'm thinking going
There's a lot of good stuff, keto food available, as long as you're supplementing fat on top of it and you're getting the keto stuff at the store, because you need that extra fat, good fat. Yeah, there's just so much available now that's tasty stuff that they used to not have. So that, in that way, the keto diet that people do for weight loss has been very helpful because it's provided us with all these low carbohydrate options.
I have a question. How many of you have or have children who've been on keto? Any of you considering a ketogenic diet?
Yes. It's true in adult. Again, adults don't tolerate the higher ratios. I'm not sure about geriatric since I do the little guys.
So, are you asking for epilepsy? Yeah. Yeah, so.
Oh, you get the geriatric.
Yeah, so, I mean, I would recommend anyone try it if they don't have any, contraindicating metabolic disorder, which that one probably don't. But, you can't go to as high of a ratio of fat to non-fat, so you're gonna get as high of a ketone level. But some people don't need that high of a ketone level, so if nothing else is working, I'm a big proponent of keto.
Can I ask a question?
Yes.
So he's already celiac like you. I was so glad when you asked that. So he's celiac, and so he's way more controlled on a celiac-free, gluten-free diet than if we were to go that route with him, because we're already used to certain foods and doing that. My husband and I would go to, can you do this without a gallbladder? Is there a way to do
Yes,
keto?
you can do keto without a gallbladder.
So we would just do the whole family. That's, I think, the easiest route.
Yes.
Yeah, that's not a contraindication, surprisingly.
Yeah, okay, wonderful, thank you.
Yes.
One question for ketogenic diet and modified atkins. Why does episode cause a lot of positives for yours and
Why does Depakote?
cause a lot of false positives for yours?
There's
Go ahead.
some evidence that Depakote lowers ketone levels for some reason I don't fully understand, but there's been a few papers showing that. They did some kids who were on keto and Depakote, and were having great seizure control, and they actually weaned the Depakote down, and seizure control got better, and ketone levels did increase. That's all.
Well, and in medications with contraindications, another one are with topiramate and zonisamide, which already have a higher risk of causing kidney stones. You have to take that into consideration when you're on the diet because you're on two things that potentially could cause kidney stones. Yes.
Well, I would just like to share that we started it when my daughter was in her 30s, and we tried to do it on our own. And once we had supervision from a medical center, her seizures have dramatically decreased. I mean, we're talking like 6 or 8 a day to 2 a month. And so the difference that the professionals made was, transformative to her health. So for anyone thinking, oh, I can just do this on my own, I highly recommend getting professional help. And we get all these lab work every 3-4 months, so we can see if she's headed towards a kidney stone and all of this stuff. And I think the MCT oil has been really.
And that's why I brought up that doctors are important, nurses are important, but in this case, the dietitian is very important, working closely with the family because there are little nuances to getting the most ketones and the best tolerability. So it's hard, and that's one of the hardest things why a lot of places don't have programs. It's because they don't have a dietitian that can do it. My daughter's in school for a master's as a dietitian, and she's already said she doesn't want to do ketogenic diet. So I think it's hard to get people involved.
Thank you for bringing that comment up because it's true. And it grieves me when I meet families who said, we tried it and it didn't work. And they've given up on something, but
it's so much more reduced if you have evidence.
Yes,
Right.
and it's nice that keto's become so popular at large, because there are a lot of things on the market, but the information on the internet for keto is not therapeutic keto.
Yes.
You said something about blood in the urine. Is that a possible side effect of the keto diet?
No, that just sometimes you get it, and we think, could that be kidney stone? So then we usually get an ultrasound.
Yeah, our daughter had that.
Yeah, so it's one of the things that sometimes because we do the urinalysis when they come in, and we're checking for calcium and things, looking at stones. But if we see the blood, then we just go ahead and we do the ultrasound. But it's not a typical thing.
It's not if you do the ultrasound, it's not the kidney stones, but they still have the blood.
So what was that?
So, you go ahead and sometimes you see the blood in the urinalysis, okay? You do the ultrasound, and the ultrasound shows that they do not have kidney stones. So sometimes you can just get blood unexplained.
Right, sometimes you can, but we have them follow up with nephrology. We're lucky enough that we have nephrology almost right next door, where we have them follow up just to make sure that, because sometimes you don't see the kidney stone and they actually have kind of sludging and things from calcium deposit, and so we'd like to get them involved early on, the nephrologist, just to make sure nothing else is going on.
They could never figure it out. I mean,
Sometimes they don't, and they just go, well, they have blood in their urine.
rheumatologist and they
Visible blood too in the urine. Where you can actually see.
I think that would be a rare occurrence. I don't think that's a common issue.
it's a common.
It is not a common issue. It makes me wonder what else might be going on.
She had a whole book of everything, kidney biopsy, everything.
They couldn't find.
Did it resolve?
After she came off the diet, and MCC said,
So, clearly there's a lot of mixed results, but a lot of success with the ketogenic diet. But yet there's still doctors that either don't believe the results or are outright dismissive of it.
Yep.
Any suggestions if you're put up against this with a doctor that doesn't seem to want to, or kind of just very dismissive of it, of how you can still navigate it, what are the results to try to counter that? To try to get
I mean,
special
it's
support?
the data's out there. They just like I have patients. Doctors in the area that won't use Epidiolex because they just don't think it works, even though there's data that shows that it works. I don't know how to get them to get on board. We had one that chased a patient down to tell him not to go on ketogenic diet when they were coming to see us. So there's some that just don't believe it, and that's why I think I don't know if it's going to change anything. When I call it ketogenic dietary therapy, it just sounds like a real thing because I think it's just got a bad name. And I think it was, for a long time, it was probably poorly done. And people in their institutions, when they were training, they didn't see good results or they didn't have good dietitians, things like that. So I think it's difficult. I think the more programs you have, the more new neurologists you're producing that are thinking in terms of ketogenic diet and other therapies.
I think also, my experience, I think, has been that from families coming to us and telling their story, I think that physicians that trained somewhere that didn't have a ketogenic diet program when they're doing the residency didn't see the benefits. And then they hear the food tastes bad, it's hard to do, because that's what they tell their patients. But I think it's rooted in they don't have the experience and they don't have the support staff, a dietitian or whoever, to help them. And if it's something you want to try, I would suggest going somewhere else, because if the doctor isn't supportive, they're not going to get on board most likely. And I'm not sure where you're located, but we have a keto program at Duke. And you can also look at the Charlie Foundation.org is a great source of information on the ketogenic diet.
Mm-hmm.
Yeah. It was started by Jim Abrams, movie director. I love the story. His son had epilepsy, and he started the foundation as a grassroots approach to help families go to providers and say, we want this treatment.
Yes.
So I just want to speak out that the ketogenic diet is based on Johns Hopkins. They are the originators of the diet. So if you want a real wealth of information from how it began and where it's at, you go to Johns Hopkins and lots more of your information. But now it's reached out many years later to others that thank God you're finally looking, others are looking into this and taking it very seriously. My daughter, who has a rare condition, is actually diagnosed 25 years ago. 25 years ago, ketogenic diet was like looking in a swampland for something that did not exist, and Johns Hopkins was behind all of that and making it clear that it was a successful method for treating people, especially kids, out of their seizures. We had huge success when we followed it to a T. It is tough as nails to follow it. It's hard to find all those things you said. It's like your psychic look at you. I'm like, my daughter's over here, I hate the way it tastes. It's too difficult. I can't do it. I'm hiding in my bedroom to eat a bag of potato chips. Atkins came out modified as she was in her teenage years, and it was a bit of a saving grace because I was able to kind of get her to accept the situation. Many of us with our children or our adults are dealing with the fact that they are facing a condition that will be their life and what they have to do to maintain their sanity. She also has status epilepticus, so it was a nightmare, let me just tell you. And so it came out of the blue, and I searched every single thing. I'm part of that generation that is making this event happen. We wouldn't even have you guys here. 25 years ago, I was very serious about it involved in politics and everybody across California, all over the East Coast up to Washington State. So it's lovely to see you all. I'm happy to hear that news about your daughter, and it's wonderful that you guys are here. So thank you. But do remember, Johns Hopkins is a wealth of information, and they're free about it, and they help others in other states, other medical help, everything. They want everyone to know about this possibility. Okay. Thank you.
Thank you.